In fact, there's studies that people with bipolar illness, when they hit the mental health treatment community, it takes on average 5 years for the correct diagnosis to be made. So we miss it all the time. So it's something we really drill into people that were trained, residents and medical students, got to make sure they're not bipolar. So the obvious things you want to ask about, and again, this doesn't take long either. You can do this in about 2 to 3 minutes. Is there a past history that you've had of mania? Is there a family history of bipolar disorder? What's your past response to antidepressants? So there's 2 options there. If you've seen patients who've been on antidepressants over and over and they don't get better, then you want to rethink the diagnosis. Maybe they don't need antidepressants, they need mood stabilizers. Or secondly, if the response is too good. Gee, doc, I took fluoxetine when I was 5 years ago, and I was the life of the party. I was the happiest I've ever been. I was social, I was driving fast, having a good time. So too good of a response to antidepressants can be a problem. Also, age of onset. Those who have their depressive illness early on in life, particularly adolescents, think first bipolar, and then think unipolar, then the quality of the depression. So, what we said with depressive symptoms, you can sleep too much or not enough, eat too much or not enough. There's those different patterns. When you think of the quality of bipolar depression compared to unipolar, is people tend to be like hibernating bears, right? They're hyperphagic, they want to sleep all the time, they're sleeping 16 hours a day. So it's not 100%, but if you see a depression where they're sleeping all the time, eating all the time, gaining weight, cycle motor slows down versus agitated, you're thinking more perhaps bipolar depression. So it's just something to think about. The other thing you want to rule out is substance abuse, because people who are using substances often have episodes that look like mania that are not. So if you have a substance abusing patient, the 2 questions to think about are, number 1, what's the longest period of sobriety you've had? If you had episodes during that time, and also genetic family history tells you something. The other thing, which isn't quite as community standard, nor I think has as much specificity, reliability as the PHQ, is the Mood Disorders Questionnaire, MDQ. So you can also give this to your patient in the waiting room, and they can check it off. And this looks for symptoms related to mania. And so when the patient comes into your office, you can look at that, and you sort of look at this and see if they might have more of a manic type of presentation. And there's a lot of things about mania that people ask. Are you driving fast? Are you spending too much money? Do you gamble? Many of us probably do that episodically, right? All those different things. So probably the most objective, simple thing to ask patients is, are there periods of time lasting days or weeks where you sleep less? Even though you sleep less, you feel like you don't need sleep, you're more energetic, right? So that gives you more of an objective biological view of whether the person is actually having mania. So using any antidepressants, this is called the Kupfer curve. It came out about 15, 20 years ago. So we in psychiatry think about this in our heads all the time in terms of treatment of patients. So what you have is people who are asymptomatic. They start getting more and more depressed here. Get them an antidepressant medication, and they start getting what you want is a response. Response is 50% improvement of the depression, and what you want is full recovery, remission. Remission is where you're 100% and you're not having any depressive symptoms. And so you go from the acute phase, which can last anywhere from 6 weeks to 12 to 15 weeks, to the continuation phase where they are free of symptoms, and you want to stay on an antidepressant for at least 6 months. Right? Because if you don't, you have a very high rate of what you don't want, which is relapse. So what I tell my patients is, gee, I'm glad you're feeling better, but you need to keep taking your medication at least 6 months, because this is like having a strep throat. You might feel better in a few days, but if you don't continue taking the medication, you're going to have a relapse. So this is critical. And even more critical is those patients who have had 2 or more, 3 or more depressive episodes, they're going to need to be on antidepressants. Many of those people lifelong to prevent episodes from happening, but they're going to have recurrences. So what you want is response, remission, and recovery. What you don't want is the 2 bad R's, which are relapse and recurrences. PHQ, Patient Health Questionnaire, number 9 is that question about suicide. And there was just an article this past year in the Clinical Journal of Psychiatry looking at, in the community, looking at over 500,000 patients who have taken the PHQ, it was like 1.5 million times, and correlating that with actual suicide attempts and suicides. And there's the good news and the bad news about that. the PHQ-9 in the community is very good at predicting long-term those who are likely to attempt suicide or complete suicide. Right? But it's good over that 2-year period of time. It's not particularly good in terms of somebody sees you in the office or in the clinic, and are they going to go kill themselves, within that next week? Unfortunately, we don't have any good, reliable scales at this point, or tests that can tell you who's more likely to kill themselves immediately after they see you. Question.
So how many different languages have been translated?
That's a great question. I do not know. I'll have to find that out. But again, this is very widely used. I'm sure that's a very good question. I will look into that later.
Is there any similar correlation like this to, like someone might commit suicide, be thinking of suicide, but what about people who go out and hurt other people? Is there a similar, is that related to depression when people, they don't hurt themselves, they go and hurt other people?
Yeah, that's a good question. Yeah, this rating scale is not related to aggressive behaviors, so I'm not sure. This tool definitely is not used for that purpose. That's a good question. We in our hospital setting, we've been looking at different aggression type scales. Again, I couldn't tell you specifically about that at this point.
Do you think that many of the violent crimes are related to depression, when people go out and hurt other people?
Probably not. I mean, that's an outstanding point. With all this violence out there, the first reaction by public policy is you got to keep guns away from people who are mentally ill. But that's really skewed, I think. There's more people with mental illness are damaged by violence from others than them hurting other people. So I think it sheds a really bad light on people who are mentally ill. I think it's really flip-flopped. So PHQ-9, again, it's predictor who's going to harm themselves long term. But in the short term, we don't have good studies. But what I can tell you is we have done studies in terms of people who come into psychiatric hospitals, and you can see people who commit suicide in the psychiatric hospital. And there you have some good data, and you have charts to review to see who's most likely to kill themselves in the hospital after admission psychiatrically. And what you find is all those risk factors we think about: age, sex, prior suicide attempts, combat experience, substance abuse, gets thrown out the window. It's irrelevant in inpatient psychiatric suicides. What you found is the most important factor acutely is anxiety. Right? So if you look, I was telling my med students, think about if it was the night before your final exam in med school, you really hadn't prepared, and you're really anxious about taking the test next day, multiply that by 10, and think about that going on for days and days and days and days. After a while, you just can't stand anymore. So in terms of acute risk factor, certainly in acute psychiatric setting is anxiety, but I would think that extrapolates also in terms of intermediate settings in the outpatient office.
Question here.
Yes, question.
Sorry. Going back to your point about the cultural issues about whether or not you're going to admit that you're depressed or not.
Yeah.
Has there been any work done on these forms? Because they seem, if you don't want to say that you're depressed because of the way you were raised, are you going to fill out a form that says, I want to kill myself?
No, probably not. So again, the suicide's a different issue, but in terms of, again, because these are used cross-culturally in terms of, when we do research study on depression here, England, China, it's all the same. It's based on DSM-5 criteria, so it's standardized in that way. So again, even if they don't feel depressed, loss of interest in activity, which is more related to biological issues, is going to pop up there. So this does show cross-cultural reliability.
Well, I think my question is more, do people feel more comfortable revealing that, because they probably know that they're depressed, right? Or they might
Some
have
people,
some sort of
actually culturally, some people don't. So again, they think of depression, we think often of depression in terms of how you feel. Again, as equally important as how you're functioning. So, I'm losing interest in activities, but I can't sleep, I can't eat, I can't concentrate, I have appetite. So a lot of people really don't realize they're depressed when they're in major depressive illness. And part of the problem, I think, is we use this term depression, major depression. They should have named it at different moments, illness X. Because we think of depression in terms of how we feel, but it's really a specific syndrome with these constellation of symptoms.
Just really quickly, there's at least 80 languages in the translation, and there are multiple types of French, types of English, and so on. So just about everything is available.
Thank you for checking, yeah. So again, PHQ 9 is really is widely accepted use throughout every place now.
I have a question because as part of the LAPTN, we're trying to have more doctors use the PHQ-2 and
Mhm.
9 for both screening and monitoring of depression. And then I know within the Department of Mental Health, they're rolling out the Columbia Suicide Severity
Yeah,
Rating
right.
Scale. So what are your thoughts on that scale, and does it identify things maybe quicker?
Yeah, the problem again with, if you look at the frequency of suicide, it's the most high intensity but low frequency event. So to try to do it in a statistical way to look at variables is very, very difficult. So again, when I look at my patient population, I have a pretty good sense of who's at high risk of suicide over the next 2 years, 3 years, 5 years. In terms of who's going to actually kill themselves when I leave my office, it's very, very hard for me to predict. And again, I think this is very accurate in terms of our inpatient psychiatric data, it's anxiety. So if somebody comes to the office and very depressed and very anxious, you don't get the anxiety control very quickly, that's going to be a higher predictor for suicide.
Sorry to keep asking questions, but for those of us who don't work in the area of psychiatry, could you define anxiety?
Oh, well, that's an interesting point, because when you ask patients about that, they'll often ask the same question, what do you mean by anxiety? So, anxiety is, on the one hand, a subjective feeling of discomfort, inner tension, agitation. Again, there comes their cultural feelings about that. Like somebody is so the question is like, I can't get out of bed and go to work. Well, is that because you're depressed or you're anxious? So typically, depression is, boy, it's just so hard to get out, I don't have any energy, it's just I don't have the emotional oomph, as opposed to, I'm like, I feel nervous, bad's going to happen when I go out there. In psychiatry, we have a disorder, generalized anxiety disorder. And other than the feeling, the other component of generalized anxiety has to be physical symptoms. So muscular tension, somatic symptoms like headaches, body ache. So there's physical symptoms as well as emotional when it comes to anxiety. So again, if people can't speak the language of emotions, feelings, anxiety, then you ask about some of those physical symptoms also.
So I'm just thinking about the beautiful story that Jacqueline told us at the very beginning of this, where she was diagnosed with a severe heart condition, and that, of course, was very upsetting, and she found herself crying,
Yeah.
which I hope that there is a standard for dealing with that aspect of getting a terrible diagnosis. And
Yeah, that's absolutely correct. So again, it's a problem with nomenclature. So there's a difference between feeling depressed or feeling anxious, which is common, normal, healthy human reaction to bad things happening, to what we said about DSM-5 and PHQ-9, there's that bottom line that has to interfere with functioning. So if a person's reacting to an illness and is depressed, normal, understandable, let's talk about it. But if it's affecting their functioning, gee, I can't go to cardiac rehab, I can't call my doctor to get the results because I'm so anxious. If it's interfering with functioning, well, that's one way we think about it, is crossing the line, we're going to get more aggressive with treatment.
And it has to have a certain period of time too, right?
Yeah, specifically with major depression, dealing with a 2-week period of time.
Right.
And again, it's this global collection of symptoms to make the diagnosis, those top 2 and then 5 out of 7. So it's not just feeling depressed or sad or reactive to what's going on. So on the one hand, we don't want to overdiagnose. There's way too many people in the U.S. getting antidepressants. We want to diagnose and treat based on very specific criteria. And again, PHQ-9 is very much standardized with very good reliability and specificity.
One of the issues, I belong to a lot of support groups with heart patients. And so you get diagnosed with heart disease, and all of a sudden it's like, oh my God, I'm gonna die. And I've got all these things to do, and I'm overwhelmed because I gotta do all this stuff because I might not be around from my grandkids, and what am I gonna do? I gotta do all this stuff real quick, you know? And so is that a type of depression? And also, there's, when you mention depression to people, of course there are different cultural issues that come into play, but a lot of people, there's a stigma, like that word depression. I think they're saying I'm crazy. So no, I'm not depressed. you know, and I think that's a block
Yeah.
from people acknowledging, you know, something that they can get some help for.
Yeah, absolutely. So, again, I think that's where it takes a lot of time, energy, explanation to talk to people when they're going through these serious major medical illnesses, to help them understand, number one, nothing wrong with wine. There's nothing wrong with feeling like I'd rather be dead. Right? We all, many people feel that sometimes. So there's nothing wrong with expressing those feelings, and that by itself, not one specific, one or two criteria is going to make the diagnosis of major depression. It's important to talk to the patient, listen to the patient. But if they cross that line over whether these multiple symptoms and it's affecting their functioning, then it's a disservice if we don't help them to aggressively get out of that. So they have the emotional and physical energy to deal with whatever they have to face, going to cardiac rehab, taking their medications. So in some cases, it's a somewhat fine line. Other cases, it's pretty clear cut. Question?
Regarding, going back to anxiety as an acute curative risk, would that link into, or can you comment on folks having severe panic attacks and that tying into that anxiety factor?
Yeah, so people often come to the office and say they're having panic attacks, but they're not having panic attacks. So people have very high levels of anxiety, but panic attacks specifically is the level of anxiety where you feel you're going to die physically. And these people end up in emergency rooms. And other things, people say, yes, and well, how long have you had this panic attack for? Well, it lasts for all day long. That's not a panic attack. So panic attacks come on very quickly like an earthquake. It lasts 5 to 15, maybe 20 minutes. And may afterwards have this sort of reverberation like aftershocks. But the panic attack itself is very sharp, it's very specific, and comes and goes. And oftentimes people with true panic attacks wake up in the middle of the night in a panic attack. So it's like some other psychiatric illness. People come in saying they have it, but you have to be very clear. And the importance of this and clarity in terms of diagnosis is because you can't get if we don't have a unified body of information for diagnosis, then studies don't make any difference, right? You need a specific disorder in order to see if certain things are going to help that or not. So again, PHQ-9, DSM-5, they're very standardized. That's the standards that we use.
I have one final question just now, and then we'll.
Yeah.
Dr. Gonzalez?
Oh, this is.
Oh, sorry, there was another
Mr.
one.
Lava? No?
Mine may be answered later as I keep looking. So in patients with cardiovascular disease, is there you mentioned 6 months earlier as for like how long you would want to stay on an antidepressant. But I know that oftentimes weaning off of an antidepressant can be difficult at best, if not impossible.
Yeah, very good point. So the
Could you
issue is.
reiterate it, because I couldn't hear it?
Yeah, so the question is the length of time to keep a person on antidepressant. I said 6 months, should have been more clear. 6 months is the minimum, by all means no shorter than 6 months. But if the person's continuing to have chronic stress, dealing with medical illnesses, dealing with a divorce in graduate school, then that certainly can be prolonged. That 6 months is the shortest period. And as far as other question about people coming off antidepressants, some are easier than others in terms of withdrawal symptoms. So we'll talk about a couple different antidepressants and go over that specifically. Let me finish up quickly about suicide, which is important, and then move on. So protective factors, we learn a lot over the years in terms of risk factors for suicide. The other thing they're really dealing with today are protective factors. So from a trying to understand clinically if the patient's at acute risk, as well as from a documentation standpoint, protective factors are very important. There's a psychologist who did some ratings by the name of Kronsky, and he came up with the 4 F's. So his 4 F's of protective factors are family. Well, gee, I won't kill myself because it'll hurt my family too much. Faith, I believe that God will protect me, and so I'm not going to kill myself now. Future orientation, gee, God, I'm ready to leave the hospital. I won't kill myself because I got to get back to school next week. The semester's ending. And then 4th is fear of failure. That, gee, if I try to kill myself, I'm going to end up quadriplegic, so I won't do that. So family, faith, fear of factors, future orientation. So in the psychiatric setting, often people are leaving the office or leaving the hospital. They're chronically suicidal for the next 2 years. They're high risk. So I want to make sure they're not going to acutely do it, I think, in talking about protective factors, and also very important in terms of documentation. Let me go on to some specific issues related to cardiovascular disease and diabetes here. So there's probably 2 pivotal studies related to depression and cardiovascular disease, which is the SAD heart study and the ENRICH study. So SAD heart stands for, I think, a sertraline, antidepressant, heart attack, something trial. So it's about, these are patients who are post-MI, and they're using sertraline as an antidepressant. Sertraline is an antidepressant medication, been around for probably 15, 20 years now. And what they found in this study is that sertraline is both safe and effective for these patients who are post-MI. And there's actually a sub-study from this. Actually, we're talking about platelet activation. Actually showed reduction in platelet activation using sertraline in these patients post-MI. So out of this particular study, and then there's the ENRICH study, which looked at patients post-MI and treating them with SSRIs. And there was like a 42% reduction in future MIs and complications. So between these two studies, what we find is that SSRIs are considered to be probably, at least from a literature standpoint, safe and effective in terms of antidepressant medications. But all SSRIs are not created equal, serotonin-specific reuptake inhibitors. So again, this study specifically looked at sertraline. So sertraline specifically is considered one that's safe and effective. And there's another study that was done in Canada, it's called CREATE. And the CREATE study, they looked at citalopram. So citalopram was found to be safe and effective. So the American Heart Association is saying that first-line antidepressant treatment, even post-MI, is sertraline and citalopram specifically. Good news for us, those have been around for a long time, and so we're very comfortable with them psychiatrically. And from a standpoint of in terms of discontinuation syndrome with antidepressants, some are worse than others. Sertraline and citalopram are pretty midline. So when it comes time to take people off these medications, it's not very complicated. In terms of diabetes specifically, there's not one or two pivotal trials with depression and diabetes, but Lancet came up in 2015 with a meta-review of about 12 different trials or studies looking at antidepressants with patients with diabetes. And I think 7 out of those 12 studies use SSRIs. All the studies were found to be helpful in terms of reducing depression, and the 7 studies with SSRIs seem to indicate that SSRIs are effective for both treating depression as well as helping glycemic control. So in all these studies, we're looking basically at the SSRIs. And again, based on some of these studies, the American Heart Association 2008 Advisory Committee, again, patients taking SSRIs at a 42% reduction in death of recurrent MIs, and they're considering sertraline and citalopram to be the first-line antidepressant drugs for treatment of these patients.
Is the 42%, is that just related to cardiovascular disease or all-cause mortality, including suicide?
I believe this is cardiovascular disease. Now, the proviso to this is this, and something to think about. If a patient, say, has a prior history of depression, and they have an MI, but they've had a good response to another antidepressant, you don't want to introduce something to the body that may or may not be effective if something else worked in the past. But you need to make sure that's not contraindicated in some way. Right? So things to think about. Prior to the SSRIs with the tricyclics and the MAOIs, these are cardiotoxic. You see, these are really contraindicated in your cardiac type patients. Again, when I was in residency before we had SSRIs, before we had Prozac, fluoxetine, not uncommonly to see people overdosing and dying because of their antidepressant. The tricyclics, you could save up a 2-week supply of antidepressant and die by overdose. And so the other sort of shift that happened because of that is once we went to SSRIs, paroxetine, fluoxetine, citalopram, since they were so much safer than these drugs in overdose, people started passing them out like water. And that's why there's this flood of antidepressants out there, people who don't need them because they don't meet criteria. They're just appropriately sad, dealing with stress, but they're given antidepressant medications when they don't need it. The reason for that is because as we came up with safer antidepressants, unfortunately, they're given out more indiscriminately. Other considerations is in picking an antidepressant is weight gain issues and metabolic issues. So one of the forms of treatments we use with antidepressants these days, although not so much with primary care, is using antipsychotic augmentation. So you see TV commercials for this. If you're not responding to this antidepressant, they have this other thing, so we call atypical antipsychotics. And they all tend to have a propensity towards metabolic issues, most of them, as well as weight gain issues, so you have to be careful with that. And certain SSRIs have a higher rate of metabolic issues, so even though they may be safe in some respects, you don't want them to gain weight. Things like paroxetine cause a lot of weight gain. The one specific medication which is interesting in terms of diabetes is duloxetine. Right, so when duloxetine was launched about 10 years ago, it had 2 FDA indications when it came out. Right? Treatment of major depression and treatment of diabetic peripheral neuropathy. And so we use duloxetine for diabetic peripheral neuropathy. Since that time, it's also got indication for fibromyalgia, as well as chronic musculoskeletal pain related to back and knee pain, as well as generalized anxiety disorder. So again, duloxetine has been found to be safe and effective in diabetic patients. If they have microvascular disease, if they have peripheral neuropathy, and they're depressed, you hit sort of 2 birds with 1 stone. These are the different classes of the antidepressants. Again, we have the MAOIs and tricyclics in the 50s. Then we have in the 80s, we have this sort of collection. SSRIs came out in the 1990s. And then we have the SNRIs, which are both serotonin and norepinephrine. And the big thing these days, a lot of TV commercials are adjunctive antipsychotics, which you add then the antidepressants to help with depression. Then we have the 4 newest and latest antidepressants here. So the goals of antidepressant treatment really in this patient population is twofold. You want to certainly control the depression, but you also want to improve cardiac prognosis and glycemic control. And again, what we mentioned before, one of the ways that we're trying to do that is more collaborative care, right? Not for just the psychiatrist to treat depression and just the other people who treat the cardiovascular or other disease, but having actually non-physician type people who are being supervised by the primary care doc and the psychiatrist. You have more collaboration to be able to control both illnesses, not everybody in their own areas. Yes?
Do any of these studies actually include the psychotherapy and a coping mechanism? Because anything with acute or chronic illness, as they've done studies, without any medication, but just by, coping mechanism and behavior modification, things like that, they have help.
They are, and I will get to that, but actually the Enrich study actually looked at SSRI plus cognitive therapy in terms of reduction in mortality and morbidity. And in that particular study, the addition of cognitive therapy did not make a difference in that particular study.
Because one of the things a lot of physicians you want to add on is some good nutrition and the exercise that goes with the cardiovascular side of health.
Yeah.
And I just wondered, does that also play a role in helping people stay, to help with the depression component and the symptoms of that?
Yeah, absolutely. So I'm sort of a little bit hyper-focused probably on the pharmacology on this. But the reality is what you're saying is equally important. So I want to be specific about what medication to use and not to use, but the reality is behavioral therapy, cognitive rehab, and all, education, dietary, all that is critical, both in terms of the depression as well as treating the cardiovascular disease. Question?
For the cardiologist and also for the psychiatrist in terms of the standard of care for communication for that patient, I mean, one would assume that there should be that as far as the communication, but any observation or discussions in terms of, of that patient as far as the communication with both the psychiatrist and the cardiology?
Yeah, so the question is communication between the psychiatrist, cardiologist, and again, to be quite frank, in the real world, I think it certainly doesn't happen as much as it should, period. It just doesn't. So that's why I think we need education of the psychiatrist in terms of what's going on in these areas, and education of primary care in terms of what we're doing. Again, this idea of collaborative care, so I think realistically, oftentimes the physicians may not have enough time to do all this. So in collaborative care, you have, say, a nurse practitioner or a psychiatric nurse practitioner who's really playing a pivotal role in terms of both looking at the different criteria, starting medications, monitoring the medications in a very specific way, and having some collaboration between the primary care doc and the psychiatrist. An ideal world is everybody was physically in the same location. I mean, just simple things like if you had a clinic where the psychiatrist and the primary care doc was even in the same building at the same floor, that in itself has caused a huge improvement, but unfortunately we're so split up these days.
also if the electronic medical records at different institutions could be connected.
That's a discussion in itself, but that is crazy important. But in psychiatry, like I work in a 14 hospital system, is the system that I work